What if an 8-year-old's sudden, seemingly irrational phobia of the dark, or maybe an intense bout of childhood motion sickness, was actually the very first physical symptom of a neurological storm that, well, wouldn't truly break until they were 20 years old?
I mean, it completely upends how we look at developmental timelines in medicine, doesn't it?
Yeah, absolutely.
It really suggests that what we so often sort of compartmentalize as a transient psychological phase is, in reality, the early rumbling of a lifelong neurobiological state.
Exactly. And when you are sitting in the clinic and you, the listener, whether you are a psychiatry trainee, a registrar, or just a fiercely curious clinician, you know this scenario intimately. There is this overwhelming expectation that a symptom is just a symptom.
Right, a one-to-one correlation.
Yeah. A patient comes in with a fractured radius, the radiograph shows a jagged white line, and it is a beautifully binary issue. Broken or not broken.
It's visible. It's mechanical.
And frankly, as a clinician, it is deeply comforting to see that.
Oh, completely. We have this inherent bias towards the mechanical. We really want the human body to behave like a complex combustion engine.
Yeah, exactly.
You know, if a warning light flashes on the dashboard, we want to be able to point to a specific degraded component, replace it, and just clear the error code.
But today, we are stepping entirely away from the mechanical. We are wading into some seriously muddy diagnostic waters.
We really are.
We are grounding this entire deep dive in a core philosophy, which is that psychiatry is the study of how brain, mind, and experience interact. And, crucially, how that intricate process can go wrong.
Spot on.
And I would argue that absolutely nothing illustrates that maddening, beautiful interaction quite like primary headache disorders.
I agree entirely. I mean, when we look at our foundational text today, which is Kaplan and Sadok's comprehensive textbook of psychiatry, specifically chapter 2.11 on the neuropsychiatric aspects of headache, we're forced to completely abandon that simple machine metaphor.
Yeah, we have to throw it out.
We do. And this deep dive, you know, it's not going to be a dry recitation of diagnostic criteria.
No, definitely not.
Our mission today is conceptual synthesis. We really want to help you build robust mental models to clarify the underlying mechanisms.
Right.
And ultimately to strengthen your clinical reasoning so that the next time someone tells you they, quote, just have a headache, you see the entire unseen network firing behind their eyes.
I love that. So to do that, let's start by building a mental model right now. Imagine the brain's pain pathways as a highly sophisticated, state-of-the-art home security system.
Okay, I'm with you.
In a normal adaptive pain response, someone throws a brick through your living room window, the glass shatters, the kinetic sensor tricks, and the alarm blares.
Right, which is an appropriate response.
Exactly. That is acute protective pain. It is a necessary signal telling you that something external is currently causing acute tissue damage. But in primary headache disorders like migraine, it is as if that entire multi-million-pound security system has gone completely rogue.
Yes, it is no longer reacting to bricks.
Precisely. The alarm isn't waiting for a broken window anymore. It is sounding off with deafening volume because a single dry leaf blew across the front lawn.
Right.
Or because the barometric pressure dropped by a few millibars. Or even because you ate a piece of aged cheddar.
Which is terrifying when you think about it.
It is, and crucially, it doesn't just ring, it actively locks all the doors, shutters the windows, shuts off the internal lights, and makes the house completely uninhabitable for 3 straight days.
That's a brilliant way to put it.
The malfunction isn't the environment. The malfunction is the system itself.
That is just a phenomenal way to conceptualize the pathophysiology because it really reframes our entire understanding of the symptom.
Right.
Pain, especially in the context of these primary headache disorders, is not simply a signal being transmitted from the periphery to a passive receiver in the brain.
It's not just a wire carrying a current.
Exactly. The brain is not just a screen displaying a pain metric. Pain here is a state. Yes, it is actively interpreted, it is amplified, and it is modulated entirely within the central nervous system.
So it's feeding back on itself.
Precisely. The physical experience of the throbbing head and the psychological experience, the profound mood shifts, the cognitive fog, the sensory overload, they are completely inseparable.
They are part of a unified experience.
Exactly. You cannot treat the nociceptive pain without understanding the emotional and perceptual modulation happening simultaneously.
Okay, so if we are talking about a rogue security system that essentially locks people in the dark, We have to talk about the sheer scale of this malfunction globally.
Numbers are quite sobering.
They are. Looking at the epidemiological data from 2019, the numbers aren't just high, they are genuinely staggering. Headache disorders ranked 14th in global disability-adjusted life years, or DALYs.
14th.
And perhaps more shockingly, they are the third greatest source of years lost to disability, or YLDs, worldwide.
The third greatest source of YLDs globally. I mean, let that sink in for a moment.
It's wild.
And we must be highly specific about who is bearing the brunt of this epidemiological burden. It is predominantly hitting young females.
Right.
And it is striking them precisely during their peak years of educational and occupational attainment.
Okay, let's unpack this. Let's explore the why behind that demographic reality. Why young females? Is it purely societal, or is there a hard biological driver here?
Well, it's a potent mix of both, but the biological driver is undeniably central.
Okay.
The intersection of fluctuating estrogen levels with the central nociceptive networks creates a really profound vulnerability. We see migraine prevalence skyrocket in females post-puberty.
And
it often tracks explicitly with the menstrual cycle, only to stabilize or drop post-menopause.
right, which points straight to the hormone.
Exactly. But societal factors absolutely compound this biological vulnerability. Historically, women's pain has been deeply minimized or, misattributed to psychological fragility.
Which leads directly to the massive blind spot in how we both as a society and within the medical community handle this disease.
It really does.
I mean, if a novel virus was blinding people or causing temporary unilateral paralysis for a month out of every year, it would be declared a global public health emergency.
Oh, billions would be poured into research overnight.
Exactly. But because it is, quote, just a headache, it gets brushed under the rug. The data shows that over 70% of adults endorse having headaches in any given year.
Right.
But in places with highly developed healthcare infrastructure like the US and the UK, only half of those who actually meet the rigorous criteria for migraine have seen a clinician for it in the past 12 months.
And the attrition rate of care gets even worse from there.
Really?
Yeah. Of that 50% who do manage to sit in front of a clinician, only 2/3 are correctly diagnosed.
That's incredibly frustrating.
It is. The vast majority of people suffering from this profound neuropsychiatric state are relying entirely on over-the-counter self-treatment.
So they're just buying paracetamol and hoping for the best.
Essentially, yes. They are self-medicating in the dark, which often leads to secondary complications like medication overuse headaches.
Oh, which just traps them in an even more vicious cycle.
Exactly.
Why are people suffering in silence like this? Are they just assuming that modern medicine has nothing to offer them?
Well, it is a rather toxic combination of fatalism, the societal normalization of the pain, and frankly, a history of inadequate medical management.
Yeah, that makes sense.
If we connect this to the bigger clinical picture, only about 25% of migraineurs who actually meet the criteria for prophylactic medications, meaning drugs designed to alter the brain's baseline and prevent the attacks from initiating, are actually receiving them.
Wow, so that means 75% of the people whose lives are being routinely derailed by this condition are merely bracing for the next autonomic storm.
Right, rather than actively preventing it.
That is a staggering treatment gap. But the source material also highlights a shifting landscape, which is really the why now for this deep dive.
Yes, the field is evolving rapidly.
We aren't just looking at the same diagnostic landscape from the 1990s. We have the recent revision of the International Classification of Headache Disorders, the ICHD-3, which has dramatically sharpened our diagnostic boundaries.
Yes, the ICHD-3 has operationalized the criteria in a way that removes a lot of the historical guesswork.
Right.
Furthermore, there's a much deeper clinical awareness of how migraine manifests differently across a patient's lifespan.
Because it doesn't stay the same.
No. We no longer expect a 7-year-old's migraine to look identical to a 25-year-old's. We also have the advent of incredible real-time data collection.
Like the apps people use.
Exactly. Historically, a neurologist would ask a patient to recall how many headache days they had 3 months ago, which is notoriously unreliable due to recall bias.
Yeah, I couldn't tell you what I had for breakfast on a Tuesday 3 months ago, let alone if I had a headache.
Precisely. Now we have smartphone diaries tracking symptoms, prodromal mood shifts, environmental triggers, and medication efficacy in real time.
But the real game changer, and we will dedicate a significant amount of time to this later, is The pharmacology.
Oh, the biologicals, yes.
We've seen the breakthrough of entirely new classes of biological agents, specifically the CGRP monoclonal antibodies,
Which target the precise neurochemical pathways of migraine.
rather than just acting as a generalized systemic dampener. It finally feels like the neurobiology is catching up to the suffering.
It truly is a paradigm shift. However, to wield these new tools effectively, the clinician must fundamentally understand the underlying etiology.
Right, we can't just throw drugs at a problem we don't understand.
No. We have to understand the exact mechanisms of how a normal, resting brain transforms into this overwhelming, multi-system migraine state.
So let's look under the hood. Let's dive deep into the mechanisms and the models. Because if you read textbooks from 30 or 40 years ago, the prevailing theory was almost purely vascular.
Yes, the old vascular theory.
The idea was quite simple, right? The blood vessels in the head dilated, that rapid expansion stretched the sensitive nerve fibers wrapped around the vessels, and that mechanical stretching caused the throbbing pain.
It was a plumbing problem.
Exactly, a plumbing problem. But the modern literature makes it abundantly clear that the vascular theory alone is vastly insufficient.
Completely insufficient. I mean, while vasodilation certainly occurs, and it does play a role in the throbbing quality of the pain, modern functional imaging has utterly rewritten our understanding of migraine pathogenesis.
So where has the focus shifted?
It has decisively shifted from peripheral plumbing to central neurology. The contemporary model is heavily focused on the activation of the trigeminovascular system and, crucially, its central projections deep within the brain.
Okay, let's break that down for the listeners. The trigeminovascular system. The trigeminal nerve is the massive fifth cranial nerve responsible for sensation in the face and head.
Yes, and its nerve endings innervate the meninges, which are the protective layers surrounding the brain and the major cerebral blood vessels. When this system is activated, it releases a flood of vasoactive neuropeptides. But the real revelation came from functional MRI and PETAMs captured during an acute migraine attack.
What did they see?
Well, when we look at a brain in the midst of a migraine, we don't just see glowing blood vessels on the surface. We see profound, specific activation deep in the brainstem.
Deep inside.
Yes, particularly in an area called the dorsolateral pons.
So the dorsolateral pons is essentially the master control panel for that rogue security system we talked about earlier.
Precisely. It's the central hub where the malfunction originates.
Wow.
And diffusion tensor imaging, which allows us to look at the structural integrity of the brain's white matter tracts, has shown us abnormalities in both the primary and the modulatory components of the central nociceptive pathways.
Right.
We are seeing structural and functional changes in an area called the periaqueductal gray.
The periaqueductal gray, or the PEG. For our listeners who haven't reviewed their neuroanatomy recently, let's unpack how the PEG functions. It is essentially the brain's internal master pain control center, right?
It is the ultimate descending modulator. In a healthy system, when a pain signal travels up the spinal cord, the payee evaluates it.
Like a gatekeeper.
Exactly. And it can send signals back down to release endogenous opioids, our natural painkillers, to dampen or block the incoming pain signals.
Okay.
It is the body's internal triage system, deciding how much pain actually reaches conscious awareness.
It's like the soundboard mixer at a concert, pulling the fader down on the pain channel so the system doesn't get overwhelmed and blow out the speakers.
That is a brilliant analogy. But in migraine patients, the imaging shows this mixer is physically and functionally abnormal.
So the dampener is broken.
Exactly. The dampener is broken. We also see corresponding abnormalities in the somatosensory cortex, where the brain maps physical sensation, and in the occipital lobe for patients who experience visual auras.
Right.
But this brings us to one of the most hotly debated, fascinating questions in modern neurology. It is a profound, clinical, chicken or egg scenario.
Oh, I love a good paradox. What are the two sides of the debate?
Well, the question is this. Do these high-resolution imaging findings, the structural abnormalities in the periaqueductal gray, the altered functional connectivity in the brainstem, do they represent the innate, causative genetic abnormality that makes a person susceptible to migraines from birth?
Okay, so they are born with a broken mixer.
Right. Or
Yeah.
are they the downstream consequence of years and years of repetitive, severe migraine attacks, essentially burning out and scarring the neural network?
Wait, wow. So does a pre-existing broken dampener cause the lifelong storms, or do decades of violent neurological storms eventually batter the dampener until it physically degrades?
Exactly. This introduces the concept of central sensitization.
Right.
It suggests that chronic, unrelenting, high-intensity pain can structurally and functionally rewire the brain.
It changes the architecture.
It does. The constant bombardment of the trigeminal nucleus essentially lowers the threshold for future pain. The neural pathways become hyperexcitable. In clinical terms, the episodic state eventually becomes a permanent structural trait.
That is deeply unsettling. If the state becomes the trait, it means chronic pain isn't just an unpleasant experience, it is an actively neurotoxic event.
It is.
It underscores why early, aggressive, and effective prophylaxis is absolutely critical. We aren't just trying to save a patient from a bad day of pain, we might be actively preventing long-term, irreversible neuroplastic degradation.
That is the modern clinical imperative.
Yeah.
You are trying to protect the structural integrity of the network.
Speaking of the network going rogue, I want to pivot to one of the most visually dramatic manifestations of this whole process. The aura.
Ah, yes.
Because about 20% of migraine sufferers experience visual disturbances, flashing lights, zigzag lines, or even temporary terrifying loss of vision right before the headache hits.
Right.
If the core malfunction is deep in the brainstem, how does that translate to a visual light show?
The aura provides one of the most fascinating windows into the migraine brain, and it is strongly linked to the concept of cortical excitability. Psychophysiologic studies demonstrate interictal abnormalities, meaning neurophysiological abnormalities that are present even on days when the patient has no headache.
So even when they feel fine?
Exactly. Neurons in the visual cortex of migraineurs exist in a chronic, heightened state of excitability. They're primed to fire.
And when they do fire, what is actually happening?
Well, the underlying mechanism for the aura is a phenomenon known as cortical spreading depression, or CSD.
Cortical spreading depression.
Yes. Imagine a wave of intense, uncoordinated neuronal depolarization, a massive electrical short circuit, really that typically originates in the occipital lobe at the back of the brain.
Right.
This wave creeps across the surface of the cortex at a highly specific, very slow speed of about 3 to 5 millimeters per minute.
Like a stadium wave of electrical chaos just moving across the brain tissue.
Exactly like a stadium wave. And immediately following this wave of hyperactivity is a much longer period of profound neuronal silence and suppressed blood flow, which is known as oligemia.
So it's an explosion followed by a blackout.
Yes, precisely. And what is utterly brilliant about this is that the speed of this electrical wave across the cortex, that 3 to 5 millimeters per minute, correlates perfectly in real time with the gradual expansion of the visual aura that the patient sees creeping across their visual field.
That is incredible. So when a patient describes a scintillating scotoma, those jagged, shimmering lines that look like the walls of a medieval fortress slowly expanding outward and leaving a blind spot in the center, they are giving you a real-time subjective readout of a cellular depolarization wave physically inching its way across their occipital lobe.
It is. It's one of the most elegant clinical pathological correlations in all of medicine.
And speaking of electrical storms, we really must discuss a condition that makes a migraine look almost gentle in comparison. Cluster headaches.
Yes, indeed.
Because if a migraine is a rogue security system, a cluster headache sounds like a localized, catastrophic meltdown of a nuclear reactor.
That is not an overstatement, I assure you. Cluster headaches are an entirely different beast, both clinically and mechanically. Current pathophysiological models posit that the hypothalamus, which is our deep, primal regulator of circadian rhythms, sleep-wake cycles, and autonomic function, along with central pain control regions, triggers an explosive, massive cascade of events in the brainstem.
And the source material notes that this cascade involves a dual assault, doesn't it?
It does. It activates both the afferent pain pathways, bringing sensation in, and the efferent parasympathetic pathways, sending autonomic signals out.
And the imaging here is wild. PET scans have captured massive unilateral vasodilation of the major basal arteries during an acute cluster attack.
Yes, it provided one of the first truly convincing real-time demonstrations of the activation of neuronal vasodilator mechanisms in living humans.
Wow.
It's an autonomic electrical storm, intensely localized, almost always striking right behind one specific eye.
Okay, so we've established the intense, highly neurological mechanisms of migraine and cluster headaches. They are undeniable brain diseases.
Without question.
But I want to pause here and push back against some deeply entrenched conventional wisdom regarding the most common headache of all, tension-type headaches.
Ah, yes. the TTH.
For decades, the general public, and frankly, a vast majority of clinicians, have operated on a very intuitive assumption. You are stressed at work, you sit with poor posture, your neck and shoulder muscles tighten up, and that muscular tension physically squeezes the skull, causing a tension headache.
The classic tight band around the head analogy, it sounds perfectly logical.
Yeah, it is.
But what is truly fascinating here is that the textbook is unequivocally explicit on this point. Tension-type headache is a profound misnomer.
A misnomer?
Yes. There is absolutely no rigorous clinical or physiological evidence that pericranial muscle tension is the primary underlying etiological cause of this headache subtype.
Hold on. You are telling me that when I have a long day at the clinic and I get a dull headache and I can literally feel the hard, painful knots in the musculature of my neck and shoulders, that tension is not causing the headache. Are you saying the knots are an illusion?
Not an illusion, no, but a consequence.
A consequence?
Yes. The muscular tension is frequently a secondary phenomenon. It is a reactive bracing effect.
Like tensing up against the pain.
Exactly. When you are experiencing a low-grade constant head pain, you instinctively hold your head perfectly still. You tense your neck and shoulder musculature to avoid any sudden movements that might exacerbate the intracranial discomfort.
So the tension is a reaction to the pain, not the generator of it.
Precisely. The actual etiology of tension-type headaches remains far less understood than the profound neurochemical cascades of migraine. But the purely muscular mechanical theory has been thoroughly debunked.
Right.
It is likely a combination of heightened peripheral pain sensitivity and a lowering of central pain thresholds.
That is a massive clinical pearl for anyone listening. We need to stop telling our patients that their headache is simply because they're shrugging their shoulders too much at their desk, or that they just need a massage.
Indeed. Framing it as purely a mechanical muscle issue completely invalidates their neurological experience and, well, it misdirects our therapeutic approach.
Right. So we've spent a good amount of time looking under the hood at the cellular mechanisms and debunking the old myths. Now let's walk out of the neuroimaging lab and step into the reality of the outpatient clinic.
Back to the real world.
Exactly. How do these misfiring neural mechanisms actually present when a patient is sitting across from you? This is where we need to dig into the rigid typologies of the ICHD-3.
Let's do it.
Let's start with the heavy hitter, the one that drives the majority of neurology referrals. Migraine.
The shift to the ICHD-3 brought us highly specific, strictly operationalized criteria.
Okay.
For a formal diagnosis of migraine without aura, a patient needs to have had a lifetime history of at least 5 attacks, fulfilling very specific temporal and symptomatic parameters.
Let's run through them.
First, let's look at the duration. An untreated or unsuccessfully treated migraine attack must last between 4 and 72 hours.
4 to 72 hours. Let's pause on that because that is a very specific, crucial window. If a patient tells me they had a terrible headache, but it totally resolved on its own in 45 minutes while they were watching TV, that is not a migraine.
Correct.
But why the 72-hour cutoff? Does the brain just eventually run out of the neurotransmitters required to sustain the pain?
In a sense, yes. The neurochemical storm of a migraine is metabolically exhausting.
Right.
The massive release of vasoactive peptides, the neurogenic inflammation, the constant firing of the trigeminal nucleus, it simply cannot be sustained indefinitely.
The system burns out.
By around the 72-hour mark, the system typically exhausts its inflammatory mediators, or the central modulatory systems finally manage to upregulate enough endogenous inhibition to break the cycle.
And what if it doesn't?
If a headache persists continuously beyond 72 hours, we call it status migrainosus, and it often requires an entirely different, usually intravenous intervention to break in an acute care setting.
Okay, so the temporal window is 4 to 72 hours. What about the pain profile itself?
The headache must possess at least 2 of the following 4 specific characteristics.
Right.
First, it is unilateral, meaning it localizes strictly to one side of the head. Second, it has a pulsating or throbbing quality.
Okay.
Third, it is of moderate to severe intensity. This is not a headache you can simply ignore. And fourth, and crucially for clinical history taking, it is aggravated by or causes the patient to actively avoid routine physical activity.
Simple things like walking up a flight of stairs or bending over to tie a shoe.
Exactly.
Why does movement make it worse? Is that the vascular component we talked about?
Yes, the routine physical exertion causes transient fluctuations in intracranial pressure and hemodynamics.
Of a surge of blood.
Right, which surges against the already sensitized, inflamed blood vessels and meninges, setting a massive spike of pain through the trigeminal system.
So unilateral, pulsating, moderate to severe, and aggravated by movement. That defines the pain. But as we establish in our security system metaphor, a migraine is a systemic state, not just a localized pain.
Exactly. To meet the full criteria during the headache phase, the patient must also experience at least one of the following associated systemic symptoms:
Oh, sure.
nausea and/or vomiting, or the combination of photophobia and phonophobia, which is a profound, painful hypersensitivity to light and sound.
So you are dealing with a massive multi-system presentation. It is vascular, it is neurologic, it is gastrointestinal.
It is a whole body event.
And what about migraine with aura? How have the criteria evolved there?
Well, the ICH-D3 wisely discarded the archaic and confusing terms classic and common migraine.
Goodness.
Now, the nomenclature is simply migraine with or without aura. The aura itself consists of fully reversible neurological symptoms.
Yeah.
These are most commonly visual, as we discussed with cortical spreading depression. But they can also be sensory, like a spreading numbness or tingling, or dysphasic speech disturbances, where the patient struggles to find words.
And there's specific timing to this, right?
The key diagnostic feature of an aura is its temporal profile. It must develop gradually over 5 minutes and last no longer than 60 minutes before the headache phase begins.
And there is one massive red flag here regarding the aura symptoms.
Importantly, there must be no motor weakness.
Not at all.
If a patient reports that their arm went weak or paralyzed during the aura phase, you are no longer dealing with a standard migraine.
What are you dealing with?
You're either entering the rare genetic territory of hemiplegic migraine, or, far more pressingly, you need to rule out a transient ischemic attack or an evolving stroke.
Absolutely. Let's contrast that intense multi-system migraine presentation with the tension-type headache, or PTH. Our source notes this is the single most frequent primary headache, boasting a massive 30% lifetime prevalence in the general population.
Yes, it is incredibly common.
How does the ICH-D3 practically separate a TT from, say, a mild migraine?
Clinically, the criteria for TT are essentially the inverse of the migraine criteria.
Okay.
The temporal window is much wider. A TT can last anywhere from 30 minutes to a full 7 days. The pain profile is bilateral, affecting both sides of the head rather than unilateral.
So it's all over.
The quality is described as pressing or tightening, often compared to a vice, but explicitly non-pulsating.
Right.
The intensity is only mild to moderate, and crucially, it is not aggravated by routine physical activity.
So the patient can still walk up the stairs without a spike of agony. What about the associated systemic symptoms?
This is the major dividing line. In TT, there is absolutely no nausea or vomiting.
None.
A patient might report mild anorexia, a general lack of appetite, but they will not have active nausea. Furthermore, they cannot have both photophobia and phonophobia.
Okay, so they might be slightly bothered by a bright light, but they won't retreat to a perfectly dark, silent room. Let me summarize that for the clinicians listening because it is so vital for quick triage. If a patient sits down and tells you their head is throbbing on the left side, they feel like they're going to vomit, and they had to cancel their plans to lie motionless in a dark room because the daylight hurt their eyes. That is a migraine. Full stop.
Yes, undeniably.
Whereas if they describe a dull bilateral ache that wraps around their head, but they are still able to continue working at their computer, albeit uncomfortably, and their stomach feels perfectly fine, you are almost certainly looking at a tension-type headache.
Precisely. The functional impairment is the great differentiator.
Now, let's move to the one condition that truly terrifies both the patient and often the practitioner who first encounters it. Cluster headache.
It is a fearsome condition.
We mentioned the hypothalamic autonomic storm earlier. How does this present in the emergency room or the clinic?
It is defined by sheer, relentless severity. The term cluster refers to its highly specific temporal behavior. The attacks occur in dense groupings, often several attacks per day over a period of 1 to 2 months. This cluster period is then followed by a long, complete remission that can last for months or even years.
And epidemiologically?
It is overwhelmingly predominant in males. The pain itself is usually retroorbital, feeling as though an ice pick is being driven right behind one eye.
And here is a vital clinical distinction, a behavioral difference that is impossible to miss if you are paying attention. We just established that a migraine sufferer retreats. They seek a dark, quiet room. They want absolute motionless stillness. But a cluster sufferer.
A patient in the throes of a cluster headache physically cannot stay still.
Really?
The pain is so excruciating. The autonomic drive is so high that they pace the room, they rock back and forth, they groan, they scream, and they thrash.
Wow.
They appear profoundly agitated, almost manic. I've heard emergency room physicians describe them as appearing acutely psychotic because the motor thrashing is so severe.
That sounds horrific.
It is. And physically, if you look at their face, you will see stark autonomic signs strictly on the side of the pain. Profound lacrimation, tearing of the eye, rhinorias, a runny nose, and erythema, redness of the conjunctiva.
It sounds like absolute torture. The behavioral contrast pacing versus retreating is such a brilliantly clear diagnostic dividing line.
It is.
Now, before we move on to treatment, there is one more specific secondary headache mentioned in the source that presents a fascinating clinical paradox: post-traumatic headache.
Yes. By definition, this is a headache that develops within 7 days of head trauma that involves a loss of consciousness, post-traumatic amnesia, or abnormal neuroimaging.
But here is the paradox. Intuition would tell us that the worse the physical structural damage to the skull, the worse the subsequent lingering headaches would be.
Right.
But the textbook explicitly states the exact opposite.
Is a remarkable finding. There's an inverse relationship. Chronic post-traumatic headache is actually significantly more common after mild to moderate head injuries that do not result in a skull fracture.
That is completely counterintuitive. Why would an intact skull lead to worse chronic pain than a fractured one?
Well, the exact pathogenesis is still vigorously debated, but the current consensus points away from gross mechanical disruption of bone and towards neurochemistry.
Okay.
When the skull doesn't fracture, the concussive rotational forces of the impact are entirely absorbed by the brain tissue within an enclosed cranium.
Because the energy has nowhere else to go.
Exactly. This causes diffuse axonal injury and triggers a massive, chaotic neurochemical cascade, including massive releases of glutamate and potassium.
Which sounds familiar.
Yes, which ironically mimics the environment of cortical spreading depression.
So the trauma acts as a massive exogenous trigger for a neurochemical storm.
Exactly. And interestingly, many of these chronic post-traumatic headaches eventually evolve to look phenotypically exactly like typical migraines.
Oh, wow.
This suggests that the concussive trauma didn't invent a new type of headache. It simply acted as the environmental trigger that permanently activated an underlying dormant genetic susceptibility to the migraine state.
Okay, so we've mapped out the major typologies, but headache is an incredibly common, often incredibly vague complaint. Here is where it gets really interesting, and where the clinician's anxiety usually spikes.
Ah, the red flags.
Exactly. How do we ensure when evaluating a headache that we aren't missing something imminently deadly? Let's move into integration and clinical reasoning, starting with the absolute neurological red flags.
If we connect this to the broader clinical picture, you have to remember that a chief complaint of, headache can range from an entirely trivial annoyance to an acutely life-threatening crisis in a matter of hours.
Right.
A skillful, meticulous diagnostic workup is absolutely non-negotiable.
The textbook provides us with a very clear list of red flags that demand you stop everything, order immediate neuroimaging, and initiate a massive workup. Let's run through them.
Sure.
First, the first severe headache of a person's life occurring in midlife. Second, the classic worst headache of a person's life, which notoriously screams subarachnoid hemorrhage.
The thunderclap headache.
Right. Third, a headache that gradually, relentlessly worsens over days or weeks, which points to an expanding intracranial mass, a tumor, or steadily increasing intracranial pressure.
We also must be highly suspicious of vomiting that occurs prior to the onset of the headache pain, which is temporally highly atypical for migraine.
Okay, so vomiting first, then pain.
Yes. Also, any abnormal neurological sign on examination, particularly hemiplegia or asymmetrical reflexes. An onset after age 50 is a major red flag.
Age 50, got it.
A headache accompanied by systemic illness, stiff neck, or fever, which could indicate meningitis or encephalitis. Or a headache that is so sudden and severe, it wakes a patient from a sound, deep sleep.
And for that specific over 50 demographic, there is one diagnosis the text says we absolutely, unequivocally cannot afford to miss.
Temporal arteritis, also known as giant cell arteritis.
Right.
This is a severe systemic inflammatory condition of the medium and large blood vessels, particularly the branches of the carotid artery. If a patient over the age of 50 presents with a new onset localized headache, you must urgently order a sedimentation rate and serum alkaline phosphatase to look for systemic inflammation.
And why is the urgency so phenomenally high? I mean, why can't we just give them some paracetamol and see them in a week?
Because if it is indeed temporal arteritis and it is left untreated, the inflammation can rapidly occlude the ophthalmic artery.
Oh.
It has the potential to cause sudden, irreversible blindness in one or both eyes, or precipitate a major ischemic stroke.
That is terrifying.
The treatment requires the immediate empirical administration of high-dose systemic corticosteroids. You do not wait to see if the headache resolves. You act preemptively to save the patient's vision and brain tissue.
That is a critical sight-saving takeaway. But once we've confidently ruled out the life-threatening structural, infectious, and vascular crises, we arrive at the true philosophical core of this entire textbook chapter.
The psychiatric intersection.
The psychiatric intersection. Because, as we establish, a migraine is far more than just a headache. Our source states that migraine can actually clinically mimic several primary psychiatric disorders.
This is where the artificial barrier between the neurology clinic and the psychiatry clinic completely dissolves.
How so?
During the prodrome and aura phases of a migraine, particularly in pediatric patients, they can experience true, terrifying visual and auditory hallucinations.
Really?
Yes. Migraines can manifest with profound, uncharacteristic irritability, massive mood swings, and impulsive temper outbursts that look identical to a manic episode or disruptive mood dysregulation.
The textbook offers a conceptual model for this that I find absolutely brilliant. It frames migraine not as a standalone entity, but as existing on a specific neurobiological continuum.
Yes, the continuum model.
On one extreme end of this continuum, you have epilepsy, which is characterized by rapid, explosive, highly visible neurophysiologic electrical changes. On the opposite end, you have bipolar disorder, which is characterized by much slower, prolonged, pervasive state changes in mood, energy, and cognition. And migraine sits right in the exact middle of that continuum.
It is a perfect, elegant synthesis. Migraine shares the episodic, sudden electrical instability and sensory distortion of epilepsy, but its attacks carry the lingering, pervasive, profound, mood-altering state changes akin to a rapid cycling mood disorder.
And the epidemiological numbers here, they really back up this deep shared neurobiology.
The comorbidity is staggering.
It really is. About 60% of people with migraine have a lifetime history of either a clinical anxiety disorder or a major mood disorder, 60%.
It's huge. And even more critically for our treatment approach, 65% of the functional disability associated with migraine is actually attributable to these intertwined physical and mental comorbidities, rather than just the nociceptive headache pain itself.
Wait, so the disability is mostly the psych elements?
Exactly. When a patient sits in your office weeping, telling you their migraine is ruining their life, it is rarely just the physical pain of the attack.
Right.
It is the intertwined depression, the crippling anticipatory anxiety of wondering when the next attack will strike, the social isolation from canceling plans, and the cognitive fog that are driving the profound loss of functioning.
But the temporal sequence of this comorbidity is what really caught my eye. It is not just random. It doesn't all hit at once. There is a very specific syndromic trajectory that plays out over decades. Can you break down the order of onset?
This is a vital concept for longitudinal clinical care. The prospective cohort research shows a highly specific, repeatable pattern.
Okay.
Anxiety disorders, and particularly specific phobias and panic disorder, typically precede the onset of migraine by several years.
Wait, I really want to underline this. You are saying that a childhood phobia, a fear of the dark, or spiders can statistically predict an adulthood migraine diagnosis.
Yes.
That's wild.
Now, the current theoretical model is not that the anxiety or the phobia is mechanically causing the migraine. Rather, they are both distinct, age-dependent manifestations of a shared underlying autonomic diathesis.
Explain autonomic diathesis.
It refers to an innate, likely genetic hyperreactivity of the entire nervous system.
Like the gut line is just set too high?
Exactly. A nervous system that is overly sensitive, that lacks the robust dampening mechanisms we discussed earlier, will manifest as high anxiety early in life when the brain is interpreting its environment.
Okay.
The text even notes that unusually high rates of infantile colic in babies are consistent with this highly reactive underlying state.
So a colicky baby is a hyperreactive baby.
Right. Then eventually, as the neurochemical pathways mature and hormonal shifts occur during puberty, that exact same hyperreactive network manifests as migraine.
So the progression is the hyperreactive brain shows up as infantile colic, evolves into childhood phobia or generalized anxiety, and eventually matures into young adult migraine. That is fascinating.
Really paints a complete picture.
And where does depression fit into this timeline?
Depression typically develops after the onset of migraine.
Oh.
It acts more as a secondary reactive consequence. Decades of chronic, unpredictable pain, the erosion of social support, The stigma of an invisible illness and the steady loss of occupational functioning predictably erode the patient's baseline mood state, leading to a major depressive episode.
So, to summarize that brilliant timeline, anxiety is the early precursor of the reactive brain. Migraine is the mature neurological manifestation of that reactivity, and depression is the psychological consequence of the chronic burden. That demands a completely different way to look at a patient's chart.
It absolutely demands that we treat the entire syndrome holistically, not just the isolated symptom of pain.
Which brings us perfectly to our next major area, treatment paradigms. Knowing how complex, intertwined, and heavily systemic this network is, how it spans decades and involves both the mind and the brain, how do we actually intervene?
Right.
Let's start with prophylactic treatments, the drugs designed to prevent the spark before it causes the forest fire.
The pharmacology of migraine prevention perfectly mirrors the psychiatric intersection we just discussed. Because the networks are shared, the drugs are shared.
Makes sense.
The absolute mainstays for migraine prevention for decades have been classical antidepressants. Specifically, the older tricyclic antidepressants like amitriptyline and the serotonin norepinephrine reuptake inhibitors, or SNRIs, like venlafaxine.
And the textbook makes a crucial point here. These antidepressants are highly effective for migraine prevention, even in the absence of comorbid mood disorders.
Yes, that is a key point.
So if a patient has zero depression and zero anxiety, amitriptyline still works to stop their migraines. They aren't just treating a secondary depression, they are actively stabilizing the brain's pain pathways. How do they do that?
The mechanism is neurochemical. The tricyclics and SNRIs powerfully modulate serotonin and norepinephrine levels in the brainstem.
Okay.
These are the exact neurotransmitters utilized by the descending pain inhibitory pathways, our internal dampener.
The sound mixer.
Right. By boosting these transmitters, we are essentially turning the volume of the dampener back up. Additionally, tricyclics inhibit NMDA receptors, reducing the overall excitability of the network.
But here is a massive common trap for the unwary clinician. You see a patient in your clinic with both depression and migraine. You think, I'll prescribe a modern, clean SSRI, a selective serotonin reuptake inhibitor like fluoxetine or sertraline.
And you would be making a very significant clinical error.
Why?
The literature is exceedingly clear. SSRIs have not been proven effective for migraine prevention.
Wow.
In fact, paradoxically, headaches are a very common, well-documented side effect of SSRIs. You could actively make their primary pain condition significantly worse while trying to treat their mood.
What a vital distinction. Tricyclics and SNRIs are the heavy hitters. SSRIs are essentially useless for the pain network or even harmful. What other drug classes are we using to stabilize this hyperreactive brain?
Well, because we discussed that continuum with epilepsy, it makes sense that anti-seizure medications are highly effective prophylactics. Drugs like Davalproex, Topiramate, and Velpro all show superior efficacy to placebo in preventing migraine. They work by quieting the electrical excitability of the cortex.
But there's a catch, isn't there?
There's a big catch. They carry significant, often intolerable side effect profiles. Cognitive slowing, which patients often call brain fog, profound weight changes, and severe teratogenicity, meaning they can cause birth defects.
Oh, wow.
They require very careful monitoring, especially in our primary demographic of young women of childbearing age.
And we also utilize cardiovascular drugs, right? Beta blockers.
Yes, specifically beta blockers like metoprolol, propranolol, and timolol. Remember that underlying autonomic diathesis we discussed?
The hyperreactive nervous system.
Right. Beta blockers are particularly helpful in migraineurs who exhibit high baseline levels of autonomic reactivity because they directly block the epinephrine receptors.
So they lower the baseline.
Exactly, dampening that sympathetic overdrive and preventing the vascular and neural fluctuations that trigger an attack.
And then we arrive at the absolute new frontier, the drugs that have completely changed the landscape of specialty headache clinics over the last 5 to 10 years. The biologicals.
Yes, the CGRP monoclonal antibodies.
Let's spend some time here because this is a revolution. What is CGRP?
Calcitonin gene-related peptide, or CGRP. It is a highly potent neuropeptide that is heavily concentrated within the trigeminal ganglia.
Okay.
For decades, researchers noticed that during a severe migraine attack, CGRP levels in the jugular vein absolutely skyrocketed.
Oh, really?
It is a massive vasodilator, and it triggers immense neurogenic inflammation. It is essentially the primary chemical messenger of the migraine state.
So if CGRP is the chemical messenger shouting pain, the new approach was to simply shoot the messenger.
Exactly, shoot the messenger. We now have engineered biological agents, monoclonal antibodies like eptinezumab, firmanezumab, galcanezumab, and the receptor antagonist erinumab.
And how do they differ from the older drugs?
Well, unlike older dirty drugs like psychiatrics or valproate that act all over the brain and cause widespread side effects, these antibodies are massive proteins designed to do one single thing.
Right.
They either bind directly to the CGRP molecule itself, neutralizing it before it can attach to a receptor, or they physically block the CGRP receptor on the cell.
It's like a highly targeted missile defense system specifically for the migraine pain pathway.
Exactly. And because they are so large, they generally don't cross the blood-brain barrier, which drastically reduces central nervous system side effects, like cognitive fog or sedation. They offer moderate to high efficacy with a generally spectacular tolerability profile compared to the older meds.
They are a triumph of translational neuroscience.
They really are.
So that is how we prevent the fire. But what about acute treatments? The patient is in your office or trapped in their dark bedroom, and the autonomic storm has already broken. The security alarm is blaring. How do we shut it off?
For an acute, fully developed migraine, the primary disease-specific pharmacological agents are the triptans. Right.
These are 5-HT1B and 1D receptor agonists. Drugs like sumatriptan, zolmitriptan, and rizatriptan.
How do they work?
They act via a dual mechanism. By agonizing the serotonin 1B receptors on the cranial blood vessels, they force the painfully dilated, inflamed vessels to firmly constrict.
Squeezing them shut.
Right. Simultaneously, by agonizing the 1D receptors on the trigeminal nerve endings, they actively block the further release of CGRP and other inflammatory peptides.
So it halts the pain signal right at the source in the brainstem?
Effectively, yes. We also still use older ergot alkaloids, though much less frequently now due to their harsh side effect profiles.
And for milder attacks, or for the tension-type headaches we discussed earlier?
We rely on nonsteroidal anti-inflammatory drugs, or NSAIDs, diclofenac, naproxen, or simple ibuprofen.
Okay.
Interestingly, ibuprofen is generally the first-line choice for tension-type headache due to its lower risk of gastrointestinal bleeding compared to stronger NSAIDs. Aspirin and acetaminophen are also widely used.
But there is a risk of taking too many of these, isn't there? A massive risk. The clinician must constantly beware of a phenomenon called medication overuse headache.
Right.
If a patient takes these acute painkillers more than 10 to 15 days a month, the brain's receptors adapt, and the medication itself begins to cause a daily rebound headache, trapping the patient in a horrific cycle.
And we cannot forget our cluster headache patient, the one pacing the halls in agony with the tearing eye. What is the acute intervention there? I mean, a simple ibuprofen isn't going to touch an autonomic meltdown of that magnitude.
Not at all. Standard oral medications are entirely useless because they take too long to absorb.
So what do you do?
For acute cluster headache, the first line abortive therapy is an immediate subcutaneous injection of sumatriptan, bypassing the gut entirely.
Okay.
But alongside that, one of the most remarkably effective and unique treatments in all of neurology is the administration of high-flow, 100% oxygen.
Oxygen. I mean, I breathe oxygen every day. How does that stop a cluster headache?
It must be delivered via a non-rebreather mask at a very high flow rate, 12 to 15 liters per minute for up to 20 minutes.
Okay.
At that concentration, pure oxygen induces highly potent cerebral vasoconstriction, reversing the massive basal artery dilation we discussed. It also directly modulates the parasympathetic efferents involved in the cluster attack.
That's incredible.
It is highly effective and completely avoids the systemic side effects of pharmacology. But unfortunately, getting insurance companies or health systems to cover home oxygen tanks for a headache condition can be a massive logistical hurdle for patients.
Which is a tragedy. Before we wrap up our integration, we really need to touch briefly on pediatric considerations, because children are not just small adults, and their developing nervous systems don't express migraines the same way mature brains do.
Exactly. In young children, migraine frequently presents primarily with profound gastrointestinal complaints rather than severe head pain.
We call them abdominal migraines, right?
Yeah. Yes. You'll see episodic, unexplained bouts of severe stomach pain, intense nausea, cyclic vomiting, or diarrhea, often accompanied by pallor, with a much shorter duration of actual headache than you see in adults.
And pharmacologically, our hands are somewhat tied with kids, right? The options are far more limited.
The textbook notes that the only pharmacological agents with truly robust evidence for pediatric prophylaxis are topiramate and an older antihistamine called cinnarizine. Cyproheptadine is also frequently used off-label for kids under 12.
Okay.
But in reality, the absolute cornerstone for pediatric migraine management is disease prevention through rigorous lifestyle modification.
Controlling the environment to avoid triggering the reactive brain.
Precisely. Addressing BMI, strictly eliminating dietary caffeine, enforcing rigorous, consistent sleep hygiene, and aggressively managing psychological stress.
And what about the antidepressants for kids?
Interestingly, the clinical guidelines show that amitriptyline alone isn't highly efficacious in kids. However, amitriptyline combined with targeted cognitive behavioral therapy is significantly superior to just providing headache education and medication.
Wow. So the psychological intervention teaching the child how to manage stress and downregulate their autonomic arousal physically alters the pain outcome?
It does. It really does.
Which brings us perfectly to our final synthesis. We have taken quite a profound journey today through Chapter 2.01. We started by looking at a headache as a simple mechanical physical symptom, a broken window.
But the Kaplan and Sadok text has forced us to completely rebuild that model.
We must now view headache, particularly migraine, as a complex, pervasive, longitudinal neuropsychiatric state. It involves peripheral sensory pathways, deep brainstem regulatory systems, and higher-order cortical networks.
The archaic dualistic separation of physical pain and psychological pain has been thoroughly and scientifically dismantled. In headache medicine, they are one unified experience. The pain is not just passively transmitted, it is actively created, modulated, and amplified by the very same neural networks that govern our mood, our anxiety, and our attention.
And that leads me to a final provocative thought, something I want you, the listener, to mull over on your drive home or before you step into your next clinic. We established clearly that anxiety and specific phobias often precede and statistically predict the physical onset of migraine in young adults.
Right, acting as early manifestations of a shared underlying autonomic diathesis.
We also established that decades of untreated migraine can cause central sensitization, structurally and permanently altering the brain's pain networks.
Yes, the long-term scarring of the neural network.
So if that entire developmental sequence is true, could early aggressive psychological intervention for childhood anxiety, teaching a highly reactive phobic 8-year-old how to actively downregulate their nervous system through CBT, could that actually prevent the lifelong neurological structural changes of chronic migraine?
It's a huge question.
Could talk therapy and behavioral intervention in childhood literally save the physical brain from neurotoxic pain scarring decades later?
It's a profound, paradigm-shifting question. It elevates psychotherapy from merely a tool for managing transient distress into a true neuroprotective structural intervention.
I think so.
It is the ultimate clinical embodiment of how the mind and brain interact to shape our reality.
Food for thought. All right, let's lock in everything we have discussed today with some learning reinforcement. We are going to test your clinical reflexes based directly on the textbook. I'm going to hand it over to the expert for our single best answer mini quiz.
Let's do it. Question 1. A 28-year-old male presents to the emergency department with severe, sudden retroorbital pain. He's pacing the exam room in deep agitation, unable to sit still, with a profusely tearing right eye and a runny nose. Which of the following is the most appropriate acute intervention? Is it A, oral ibuprofen 800 milligram, B, intravenous valproate, C, subcutaneous sumatriptan and high-flow 100% oxygen, or D, oral amitriptyline?
Take a second to think about that.
The correct answer is C, subcutaneous sumatriptan and high-flow 100% oxygen.
And the rationale?
The patient is exhibiting the classic signs of a cluster headache, characterized by intense autonomic signs and stark motor agitation, which is uniquely responsive to high-flow oxygen therapy and requires bypass of the GI tract.
Brilliant. Next question.
Question 2. Which of the following statements regarding the pathophysiology of tension-type headache, or TTH, is most accurate according to current evidence? Is it A, it is primarily driven by massive basal artery vasodilation? B, it is not caused by underlying pericranial muscle tension? C, it is heavily mediated by the release of CGRP? Or D, it is characterized by cortical spreading depression?
Okay, what do you say?
The correct answer is B. It is not caused by underlying pericranial muscle tension.
The great myth debunked.
Exactly. Despite the enduring name, TTH is a misnomer. Muscle tension is no longer believed to be the underlying etiology, and the neck pain observed is usually a secondary bracing effect against the discomfort.
Right. Question 3.
Question 3. A patient with a history of recurrent severe headaches asks you about their risk for psychiatric conditions. Based on longitudinal prospective studies, Which psychiatric sequence is most accurate? A. Depression typically precedes migraine and anxiety follows. B. Migraine onset always precedes any psychiatric symptoms. C. Anxiety disorders typically precede the onset of migraine, while depression typically develops after. Or D. Psychiatric comorbidity is exceptionally rare in migraineurs.
Let's see if you remember the timeline.
The correct answer is C. Anxiety disorders typically precede the onset of migraine, while depression typically develops after.
Which is that shared diathesis we discussed.
Right. The clinical rationale is that anxiety may represent a common underlying autonomic diathesis, a hyperreactive nervous system, whereas depression often occurs secondary to the exhausting chronic burden of the pain state.
Excellent. Question 4.
Question 4. Which functional neuroimaging finding most directly challenges the older purely vascular theory of migraine pathogenesis? A. Dilation of the superficial temporal artery. B. Activation of the brainstem, particularly the dorsolateral pons, and structural abnormalities in the periaqueductal gray. C. Normal structural MRI findings between attacks. Or D. Decreased blood flow during the oligemic phase of aura.
Think about the imaging we talked about.
The correct answer is B. Activation of the brainstem, particularly the dorsolateral pons, and structural abnormalities in the periaqueductal gray.
The broken mixer.
Precisely. This rationale points squarely to central nervous system nociceptive and modulatory pathway dysfunction, proving the brain itself is the generator rather than purely peripheral vascular events.
And the final question?
Question 5. A 55-year-old female presents to your clinic with a new onset severe localized headache. She has absolutely no prior history of headaches. Which of the following is the most critical initial diagnostic action? A. Prescribe oral sumatriptan and follow up in 1 month. B. Order a sedimentation rate and serum alkaline phosphatase. C. Reassure her that new headaches are common with menopause. Or D. Order an EEG to rule out epilepsy.
Think about the red flags.
The correct answer is B. Order a sedimentation rate and serum alkaline phosphatase.
You don't want to miss that one.
Never. The rationale is that a new onset headache in a patient over the age of 50 is an absolute red flag that requires the immediate ruling out of temporal or giant cell arteritis. This must be done to initiate corticosteroid therapy and prevent sudden, irreversible stroke or blindness.
Outstanding. Thank you for joining us in the muddy waters today and for taking the time to truly understand the suffering behind the symptom. Here are the details of this episode.
Neuropsychiatric aspects of headache. Byline. Pain. Pain is signal and state where sensation, emotion, and perception converge.